Perfect. Thank you all for being here. My name is Abdullah Sarhan, and I'm CEO of RetinaLogik, which is like a vision screening company that helps in like the improving accessibility for RetinaLogik for vision care, I would say. Let me introduce you to two more people. This is Daryl and his mom Beatrice. Daryl lives in a low-income area in Kenya that they don't have access to vision screening. So he has glaucoma but doesn't know it yet. When you have a glaucoma, the world gets darker and darker and darker until irreversible vision loss happens. It can be treated if caught early. Like Beryl, 2.2 billion suffer from vision impairment. However, 1 billion of those are preventable or treatable. In Canada, 1.2 million cases have vision loss, 75% caused by preventable or treatable conditions. So why the system is still failing us? Basically, there are two common exams basically done in clinics nowadays. First one is the visual field, and the second is retinal images. The issue with these technologies that have been used for the last 20 years, patients need to travel to the clinic. So in the developing world, commuting won't be an option. The eye exam is not portable, not also adjustable for people, I would say. And still optometrists or specialists need to analyze the results. The problem is that they need to be able to and willing to travel. The machines by themselves are very expensive. One of those machines are like around 20K, and you need to pay a subscription fee on an annual basis. And exams can still miss early stage conditions, which no referrals or treatments happen at this stage, which leads to advancement in glaucoma. So RetinaLogik revolutionizes vision care by making eye exam portable, accessible, and intelligent. But how? Instead of using those expensive machines, we use instead virtual reality and handheld retinal camera. And in this presentation, I'll be focusing mainly on the virtual reality as our first product market. So our innovation is portable and reduced cost, self-guided and improved patient care, and there is like improved analytics in it. It's 94% cheaper than the current available technology that's being used in the clinic. Our value proposition is that our technology is portable, accessible, and intelligent vision screening that improve vision care and improve referrals for people suffering from such conditions, I would say. We're the only solution with early detection with an international social enterprise that go-to-market strategy. We're cost-effective and designed to adapt with new hardware advancements. Our optometry market is that we have 2.6 million. We are halfway between fragmentation and consolidation, and Asia Pacific has the highest CAGR opportunity. Our target customers, we have the NGOs, we have optometry chains, and we have rural care. We already developed a relationship with access to more than 500 clinical clinics in the market. Our business model is $150 subscription fee with access to the hardware, with access to the software, and our maintenance with 85% profit margin over 3 years commitment. Our 5 years look ahead is that if we target less than 1% of our total and acquirable market with 150 monthly subscription fee, we could access around 36 million by 2026. And here's our team. This is me. I have my PhD in computer science. I've been working in the field of machine learning for the last 8 years and the field of ophthalmology for the last 4 years. And there's Julia, who has also extensive experience in the field of software development and the fields of like business and technology. So far, we've been able to develop the prototype. We've got some feedback, and we are still actually in the final stage of our clinical trials. We finished our ethics application, and then we're just moving to clinical trials next month. We've been able to raise around 65K in non-dilutive fund. We've published peer-reviewed research. We finished the software development, and our ethics are under review. Over 8 million Canadians are living with disease that can lead to blindness. Their time is running out, especially also in the developing world for people like Daryl. Thank you.
Thank you for the presentation. Svetlana is here with a question. So you so explicitly said that it is costly to go to the doctor's appointment, and in the meantime, you make it as if your service is completely free. Don't you need to have laptop or a phone, or what is the platform you need to have in order to use your software?
So our technology basically works in a way so that you only need the VR headset, and you could access the exam anywhere. Like you don't need a laptop, you don't need a phone. You could access it. Like there are some VR headsets that they require a laptop to function. Our VR headset works as a standalone, and you could access the portal that we're building through your phone, through your website, through any device that has access to that. That's basically how it works. It's different than the other virtual reality headset that requires a machine to be able to operate. Ours is a bit different.
I have a question. So are you developing your own hardware in terms of producing the headsets to detect the eye diseases, or are you using existing hardware?
Yeah, so basically we're using existing hardware because we are focusing on the software and the machine learning component, which we are good at. The hardware, because there are multiple hardwares out there. In our regulatory process, we will be focusing on 2 or 3 hardwares that are basically very common between consumers at the current stage, and we will be focusing our system works on these hardware in the market.
Very impressive. I'm just wondering about the intellectual property strategy. You have a really great approach there, and you have some, I guess, software that you've developed. Do you see that as being very protectable? And is there any support that you need on trying to find your IP strategy going forward?
We are currently looking for IP strategists. We've discussed the IP methodology with other specialists before, and the feedback we've received, because it's a software, usually it's hard to IP. You could IP the process, but we're open to discussion with IP experts as well among this for handling the IP. It's a bit tricky with software. That's why that's what the feedback we've been receiving so far.
Yeah, there are some great people on the panel here. I don't know if Trevor wants to weigh in or anybody else, but feel free to contact Abdullah if you have any thoughts on that or any other feedback, and any other questions or comments.
I'm happy to reach out, Abdullah.
Yeah, definitely. I will reach out to you. Thank you, Trevor.
I'm also just wondering about data sharing, like you're, I guess, accumulating a database there that's also fairly valuable. How are you dealing with trying to maintain confidentiality and find the value in that, and maybe even share that with, I guess, partners?
Yeah, so basically, in terms of data, each clinic will have their own data, and they would be able to detach themselves anytime they want. They have access to their own data. In terms of the centralized database, patients, the server that we'll be using will be abided by HIPAA, which is for healthcare. The data will be stored in a confidential way, and it won't be shared without user consent at the current stage. But every clinic will have their own data so that they could access it, and if they want to detach from the platform, they could do that anytime they want.
Great, thanks.